Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I will be discussing some more challenging lupus cases with Professors Ricard Cervera and Murray Urowitz from the Lupus Academy Steering Committee. Ricard and Murray, welcome, and thank you so much for joining us today.
Greetings from Barcelona.
Raquel, thank you so much. A pleasure to be here. Greetings from Toronto.
Let's discuss some lupus patient. Ricard, the first case is yours. Let's review the case history. A 39 female presented in 2012 with discoid cutaneous lupus, and the tissue biopsy had lupus band test with direct immunofluorescence. Her lab results revealed anti-nuclear antibodies positive in a high titer, low complement C3, positive low titer anti-dsDNA antibodies, and anti-Smith and anti-RNP antibodies positive also with low lymphocytes, 750 per microliter. Based upon the lupus discoid, lymphopenia, low complement and positive antibodies, she was diagnosed with systemic lupus erythematosus, SLE. Between 2012 and 2016, she also developed Raynaud's phenomena and anxiety and depression. And in 2016, she presented with a new flare of discoid lupus and polyarthritis of her proximal interphalangeal joints. She was treated accordingly. Between 2016 and the 4 next years, she was on hydroxychloroquine, topical steroids, and low-dose prednisolone for short periods. And when she presented again in June 2020, she was only on hydroxychloroquine. And she was now 48 years old, and she experienced again a severe cutaneous lupus flare with low C3, positive dsDNA antibodies, and again low lymphocytes with 617 per microliter. Ricard, I believe that this was the point when you met her with the severe cutaneous lupus flare. What were the available treatments at that point that could be considered to treat this patient? And what were the main points that you consider when choosing them?
Well, thanks, Raquel. Certainly, this was a very complex case of systemic lupus erythematosus with mainly severe cutaneous lupus flare, and that until that time was relatively well, just with topical treatment and hydroxychloroquine and low-dose prednisone. But at the time that she presented this severe flare, certainly she required additional therapy. We had the option to increase the dose of antimalarials or to add a second antimalarial. Also the option to increase the dose of oral steroids. But we believe that we had to add a new immunosuppressive drug. We have the classical options of either methotrexate or thioprin or mycophenolate. Also, dermatologists like additional therapies like dapsone, for instance, and thalidomide, which is an option that usually works pretty well for cutaneous manifestations. And also we have the possibility of adding a biological therapy that at the time, the only one that was approved was belimumab, but we have to have in mind that usually the indication of the biological therapy at the time was after the failure of at least a second immunosuppressive drug. So, taking into consideration these options, we decided to use thalidomide, that we had a pretty good experience in these similar severe cutaneous manifestations in lupus.
Murray, Do you have any additional comments on the options for this patient and what would be your choice?
So this woman does have very significant cutaneous lupus. She's diagnosed as systemic mainly because of autoantibodies. So we're really aiming at the skin here in large part in the beginning. And so I agree with Ricard that one could stay with the dermatologically favored treatments like thalidomide. I think that rheumatologists might lean more toward one of the immunosuppressive drugs, such as methotrexate here. And I think that's at least a consideration. So methotrexate as opposed to thalidomide. Some might even say now with the long-term safety and efficacy of belimumab that maybe even belimumab might be indicated here. And in the new EULAR guidelines, those drugs are considered to be acceptable at inception, rather than having to wait to get a failure elsewhere. So I agree with Ricard. We could go the dermatologic route first, see what happens, but keep in mind that an immunosuppressive drug or even a biologic might be indicated. This woman's had a pretty long history here of persistent skin disease for which she's had intermittent significant amounts of oral steroid. So we really do have to get this under control.
And she's currently 48, so pregnancy wouldn't be a major concern talking to us. So even for methotrexate or even thalidomide at this age, it's not as a difficult choice as with younger females. And she actually started on thalidomide, 50 milligrams a day, and she completely responded. Almost every skin lesion responded. She was not having joint involvement at this time, only skin lesions, and it responded. And almost 1 year later, thalidomide was reduced to 50 milligrams twice a week due to constipation and myalgia. And she started on methotrexate this time, 20 milligrams a week, but stopped it soon after due to nausea and diarrhea. She had mild leukopenia, no anemia, normal platelets, almost normal dsDNA antibodies, normal complement, and kidney function. And she was put on prednisolone 20 milligrams a day, again, not a moderate to high dose. Murray, she has severe activity, almost restricted to the skin, and this was coming and going for several years. And from your experience throughout the years, what you would expect for this patient as response? Would you target for remission now? Would you target for lowering the damage? How would you feel for so long that she has this, and what are your expectations for any treatment that comes?
So this, thank you for that. It's a very important question. Over the years, this woman, people would say, oh, well, she's only got skin. What are you worried about? Well, what we're worried about is this has required significant amounts of steroid over time, both low dose and high dose. So I think we need to make a commitment to get a remission and minimize or eliminate steroid to prevent damage. Now, I think there have been 2 attempts in this woman already. First, thalidomide, which failed for toxicity, and then methotrexate, which failed for toxicity. I wouldn't give up. I mean, it's unfortunate that neither of these worked, but I think we have to continue our commitment to try and get a remission in this woman. And so of the remaining therapies, we've tried one immunosuppressive in methotrexate. I think I would lean toward belimumab at this point in time because its effect on skin and joint are very good and its toxicity over time is safe. And I think that that would be my next choice here.
Even though she is with low serology activity, you would still choose belimumab?
Yeah, I think, you're right that we seem to have brought the serology under better control, but her underlying condition, cutaneous lupus, has not been
Yes,
under control. And what worries me is
yes.
that prolonged steroid. We're into many years now of steroid in this woman. And
And
so,
and she
yeah.
started belimumab, 200 milligrams a week subcutaneous, and she started it on June 2021. But it was discontinued in September 2022 due to treatment failure, and she was worsening depressive symptoms. And in July 2023, when she was with 51 years old, the rash worsened. It was coming and going, but sometimes with more acute flares, and it was scaly, sometimes erosive, red, and with hyperkeratotic lesions both on back, fingers, and scalp, with alopecia, and mucosal ulcers also, scoring 35 points on class EA. The polyarthritis also relapsed, and the prednisone had to be increased to 10 milligrams a day. And an interferon alpha measure was done, and it was 3 times the normal upper limit. And she was started on anifrolumab, 300 milligrams every 4 weeks, and the lesions completely resolved in 2 months. And it looks like it's also very effective as thalidomide is in smokers, which we don't know if this patient was or not. Ricard. This was your patient, and she was so not good for several years with lots of steroids. Were you expecting this quick response?
Well, we were expecting because we have this information from the clinical trials, but we certainly knew, we certainly wanted to have also the experience on real life. That sometimes it's not exactly the same that in clinical trials, and this was what happened. Certainly, the patient responded to the previous therapy at the beginning. She responded with thalidomide, but then presented side effects. The patient started to respond with methotrexate, but the side effects were so problematic for the patient that we had to stop them. Also, belimumab was doing well, not as quickly as probably we would like, but it was the cutaneous manifestations were relatively under control. We managed to decrease the dose of steroids, but then again reappear, and especially presented more depression, that that it's one of the potential risky side effects of belimumab. So we decided to stop, and then we moved to the new biological therapy, to the just recently approved. This was one of our first patients who received in real life this therapy, and certainly it worked very quickly. Just in few weeks, the lesions, the cutaneous lesions, started to decrease and certainly disappear. And he's still on this therapy and is going well so far.
Did you find such a quick answer, such a quick response to anifrolumab from the joints involvement?
At this moment, the joint involvement was not as important as severe, but just arthralgia, and certainly also responded.
Murray, do you have anything to add on this case?
Yeah, so Raquel, your question was that did the Ricard anticipate this? So I think that the word should be, did he hope for it? Well, this is very typical here. You've got patients who respond and then get side effects, and then patients who don't respond. And so far, we don't have the exact clinical phenotype or biomarker that helps us predict who's going to respond and who isn't. So often it's trial and error. It's just, if it doesn't work, let's go to the next. And that's what happened here. And luckily, she had maybe anticipated response. It happened quickly. And, in the anifrolumab studies, what differentiated it from belimumab was that the onset of action was much faster. Within 2 to 4 weeks, you could see something with anifrolumab, whereas with belimumab, you often have to wait 6 weeks to 3 months. So she responded as was hoped or anticipated. I want to put one little caveat in here is,
Yes, please.
please don't take away the drug too fast. This woman has a classic relapsing, remitting disease over a number of years. You got a remission, keep her on the medicine for a significant period of time.
Yes, and how long, Ricard, do you think you're going to keep on monthly anifrolumab? I know this is not a scientific question.
Yes, probably for several years. At this moment, she is going well. If she continues well, as Mary already stressed, we will be very cautious before we decrease or we stop. Probably we will decrease the frequency of the administration before stopping, and we will be very cautious. I fully agree with Mary.
Thank you. And let's move to a second case, which is actually from my center. This is a case of a 35-year-old Caucasian female at the present. And she presented for the first time with SLE when she was 13 years old. And she was on pediatric care. She had malar rash, alopecia, chilblains with severe Raynaud's phenomena. She was having also on her labs leukopenia, mild thrombocytopenia, elevated ESR and CRP at the beginning, high titer anti-nuclear antibodies, dsDNA, Smith, RNP, anticardiolipin antibodies, very low complement, and lupus anticoagulant was also positive. She was initiated treatment with hydroxychloroquine and high doses of prednisolone, which were tapered both, but not to less than 10 milligrams a day. And for the next couple of years, she never achieved clinical remission, always with chilblains, but not with severe activity between flares. Mucosal ulcers and lymphadenopathies were the main flares with fever, and she needed more than 10 milligrams of prednisolone to control it, and they would come back if she was with lower than 10 milligrams a day. A couple of years later, she was still on 10 milligrams a day, and she had nausea and abdominal pain that led to an abdominal ultrasound that revealed liver abscess, and she was treated for that. The prednisolone had to be increased several times for the next year, 5 years, for chilblains, skin and fever again, low complement, very high dsDNA titers. And one day, 5 years later, she was admitted due to an invasive pulmonary aspergillosis, and she was on prednisolone at the time and hydroxychloroquine. She was not on any other immunosuppressant. When she was 20 years old and on the adult care, one additional flare with fever, severe skin and chilblains led to the decision of starting MMF. And on the next few weeks, she developed a reaction, a pseudo-lymphoma-like reaction with enormous lymphadenopathies, fever, and a severe interstitial lung disease, acute, with organizing pneumonia. She was on IVIG and methylpred bolus and continued to be on 15 to 20 milligrams a day of prednisolone. Mary, how often would you see this evolution of a juvenile SLE, and would you expect this course of disease?
So, juveniles are often, juvenile patients are often felt to have more severe lupus, and so that wouldn't surprise me. what surprises me is the severity of her illness and the full house antibody positivity that
Yes.
she's only been treated with hydroxychloroquine and prednisone. And then she began to suffer some of the complications of that with increased susceptibility to infection. And let's keep in mind that prednisone is as major a precipitator of infection as all of our new treatments are. So
Yes.
we have to keep that in mind. So, yeah, I think some people will, even though she doesn't have nephritis, which kids are supposed to get more frequently and more severely, she has severe disease with lots of antibodies and lots of clinical features. So, no, I'm not surprised. It certainly does happen.
Okay. And actually, she started more than 20 years ago, the disease, but we already had several other treatment choices. And I think that, like she has a lot of infections, on the pediatric setting, sometimes we do have this kind of experience, not now, but we had some of this kind of experience. And at this point, MMF was stopped and no one wanted to re-challenge with MMF, afraid of having another reaction like the pseudolymphoma that she developed. And she increased temporarily the prednisolone dose. Then rituximab was done, one cycle, and she settled the activity for a couple of years. And despite lowering the lymphocyte count, and the attending doctor was a little bit afraid of repeating rituximab because after rituximab, she lowered the lymphocytes to lower than 500. When she flared again, fever and skin, belimumab was started, but she had not an amazing response at the first weeks or 2 or 3 months. And she was admitted not long after the belimumab to the ICU with a septic shock from a health-related pneumonia. During the hospitalization, a precapillary severe arterial pulmonary hypertension was diagnosed, and she started on combination-specific therapy with macitentan and tadalafil. And she was already on a IV pump iloprost every winter for several years due to the ulcers from the chilblains and the Raynaud's. Ricard, can you please comment on the pulmonary arterial hypertension in SLE patients? And what is your center experience?
Well, certainly pulmonary arterial hypertension in lupus is uncommon. It's quite rare, but it can appear. But I wonder if you have probably to rule out the coexistence of another disease where pulmonary hypertension is much more common, such as systemic sclerosis or even a mixed connective tissue disease. So I think that it is important to rule out the coexistence of these additional autoimmune conditions that sometimes can appear in patients with lupus.
She had an RNP antibody. No other scleroderma-specific antibodies were positive, and she had no other clinical features of scleroderma. Murray, do you have any additional comment on this particular part?
Yeah. I agree with Ricard that this pulmonary hypertension is uncommon. But when you think of what are the mechanisms of pulmonary, what are the potential mechanisms of pulmonary hypertension and lupus? Well, there are a number. For instance, small vessel vasculitis is a possibility, and that could be active lupus. She has Raynaud's phenomenon, so vasospasm can be another one. And then the other important one about other causes, as Ricard suggested, she's had pulmonary aspergillosis, so she's had diffuse pulmonary involvement. So she's got a lot of possible predictors of pulmonary hypertension. Oh, and one other. she has both antiphospholipid antibody and lupus anticoagulant. So intravascular clotting is another. So at this point, I would say, look, there are a number of possibilities, a couple of which could be due to active lupus, like the vasculitis and the Raynaud's kind of thing, which we can do something about. Clotting is another one which we can do something about. If aspergillosis has caused diffuse pulmonary fibrosis, we can't do much about that. But there are three that we can do something about, right? Two of the three are active lupus, and one of the three is coagulation. And I would be focusing on those two things now. Have we controlled her disease enough? And are we thinking about the anticoagulant possibilities here?
As our pulmonary hypertension was very severe, hypocoagulation was added from the beginning with the vasodilators. And all the tests that were used, scintigram and angio-CT, excluded thromboembolic events that could be captured for angio-CT. The catheterization to stratify showed it was really a precapillary, and the CT of a thorax at the time had some sequelae, but not in a high volume of lung that would be one of the causes of the pulmonary hypertension. And after she entered the treatment with the vasodilators, throughout the next years, she was on fluctuant doses of prednisolone as before to treat skin, mucosal ulcers, and polyarthritis. And in December 21, she had a nasty flare. She came acutely with severe skin, enlarged adenopathies, bleeding chilblains, despite being on iloprost and combination vasodilators, with extreme fatigue and arthritis. Her labs showed inflammatory anemia, profound lymphopenia, complement so low that could not be measured, and high dsDNA antibody titers. Due to the profound lymphopenia, rituximab was not considered as a first line of treatment now, and she was actually the first patient that entered the early access program to anifrolumab that opened at that time here in Portugal. And while we were waiting for the authorization to use anifrolumab on her, she had an headache and went to the emergency room. And although it resolved, cerebral brain CT was done and showed bilateral basal ganglia calcification with no other neurologic deficits. And she never had neurologic symptoms or neuropsychiatric symptoms before. 1 month after the first anifrolumab injection, the chilblains were no longer there for the first time in 20 years. The lymph glands were normal, no other mucosal ulcers were found, and for a couple of months, she continued having arthritis flares that stopped happening at the 4th or 5th month of treatment. The pulmonary hypertension lowered more than 30% of the parameters, but of course it was so severe that treatments are continued. And now she has almost 2 years of treatment and she never fled again. No more fatigue. Her prednisolone is on 2.5 milligrams a day with hydroxychloroquine and the pulmonary hypertension medication. We ran a genetic test, and due to the basal ganglia calcifications and the severe chilblains, and because she had a juvenile SLE, and actually we found a potential pathogenic variant on a gene, the PSMB9 gene for the proteasome that encodes to Kendall-Pras monogenic type 1 interferonopathy in heterozygote, and it encodes for Pras also in heterozygote. The functional tests and family members tests are ongoing, but this could be a spectrum of monogenic SLE. Murray, we thought we would never have this young lady in remission. And of course, she never did a prolonged treatment that could put her on remission due to infections and side effects. And so she was never with another treatment than steroids or hydroxychloroquine for a chronic period. What do you think of all these? What do you think about, you already said that she was only on prednisone and hydroxychloroquine, but what do you think about the case and this mutation? Would you think it's clinically relevant? What are your comprehensive comments on this case?
So look, this case is, if we're talking, if we could define her into what is her course, you know, the two courses she might fit into is either persistently active, because I don't think she's ever been in a full remission, or relapsing remitting. Both of those two clinical courses have a worse prognosis. In other words, they're the ones that lead to trouble. So the first thing I would say in the background is, it's unfortunate she wasn't treated more aggressively early on, you know, with some other agents. However, we're dealing with what we have now. And so do I think this diagnosis of monogenic lupus would change my approach? I don't think it would, you know. I mean, it just often defines a severe form, which has a familial predisposition, but it won't alter my approach now. And wow, we've had an amazing response. I mean, this is really dramatic. It happened relatively quickly for some features and a little bit slower, but definite for the other features. So I would say this is something that I would stay with. I said it before. I don't think we should ever stop our medicines too early, especially in this woman, you know, with persistently active or relapsing remitting. I would keep her on for some period of time. The one thing I'd really like to comment on, you notice that the lung parameters improved dramatically. So this indicates that there was either an inflammatory component or a vasospastic component, which came under control with this. To drop your parameters by 30% is dramatic. And so I was very happy about that. I was actually going to ask, is she on aspirin or any other?
She's on anticoagulation with the Camaro.
Good. Perfect. Okay.
Yes.
So you're treating that aspect of it, which is not as reversible, but it could be preventative for further accumulation of damage. So I think she's a relapsing remitting, starting in childhood into adulthood. And in the past, we wish we had treated her earlier with more suppressive medicines, but at the present time, she's had a very good response, and I would stay with it for some period of time.
Interestingly, clinically, she is so good, and serologically, she still has low complement C3 and C4, not as low as on the beginning. And the sDNA antibodies were on the thousands at first, and now they are pretty high yet, but probably 100, 200. It's pretty high, but still they are there. And
so that's another measure you're going to use to follow her and keep your hand, you know, stay the course sort of thing.
Ricard, do you have additional comments on this case?
Well, I fully agree with Mary, and this is really a typical example of very severe lupus of young onset, or in the pediatric ages, that it's relatively common, and several of them are because they are monogenic lupus. So one of the lessons now that we know more genes related to lupus is to test for this monogenic lupus in cases of severe lupus that start the disease in young ages, in pediatric ages. And if we can see that this patient is certainly with high interferon signature, the option to start with anifrolumab as soon as possible could be like a miracle, like was this case. So probably this is the lesson that we have to learn for the future. Young pediatric patients or patients who are now in middle ages, but the disease started in pediatric ages with severe forms, look carefully for this potential monogenic lupus, especially with high interferon levels, that could benefit of anifrolumab as soon as possible.
Thank you so much, Ricard and Murray. Thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.